Hi, my name is Jorge Mariscal and I come from the School of Biomedical Engineering and Imaging Sciences at King's College London. Today I will be presenting our most recent work on improved AI-based segmentation of apical and basal slices from clinical Cine cardiac magnetic resonance, or CMR for short. Segmenting the ventricles and the myocardium from CMR images allows cardiologists to assess cardiac function. Current deep learning models for short-axis CMR segmentation already achieve human performance for slices situated in the middle of the heart. However, model performance is not uniform throughout the heart, with basal and apical slices or regions posing a greater challenge than middle regions. In fact, differences in the basal segmentations have been reported as one of the major sources of disagreement in human inter-observer variability. In our work, we aim to investigate model performance in basal and apical slices and propose strategies to improve their segmentation. All datasets that we used consisted of end-diastole and end-systole short-axis Cine CMR images and their corresponding manual segmentations of the left and right ventricular blood pools and of the left ventricular myocardium, as shown in the image. All models were trained on a dataset of clinical CMR scans acquired at 2 NHS hospitals and including the full spectrum of cardiac disease phenotypes. These models were then evaluated on a randomly selected subset from the NHS dataset and on 2 external datasets of clinical CMRs, AC/DC and M&Ms. For each 3D stack, slices containing segmentations were considered to belong to the base, middle, or apex cardiac regions, following a 20-60-20 split, as shown. This ratio is based on cardiac anatomical knowledge and clinical experience. We used the NN unit segmentation framework to train all our models. For our first experiment, we trained a vanilla NN unit on the NHS clinical CMR dataset. This approach is considered the baseline since its performance is comparable to that of other state-of-the-art CMR segmentation methods. For the first experiment, we analyzed the regional differences in segmentation performance for the baseline approach on each test dataset. This table here shows the mean and standard deviation of the DICE scores for each cardiac region and segmentation label. Significant differences between the base middle and apex middle regions, indicated by an asterisk, were found for most labels and datasets, with the only exception of the left and right ventricular blood pools in the AC/DC dataset. After discovering significant differences in model performance between cardiac regions, we investigated 2 potential approaches to reduce this performance gap. For the first approach, we modified NN units data loader to allow for a region-aware non-uniform batch sampling. What this means is that for each mini-batch during training, slices from the apex and the base are more likely to be selected than middle slices. This is achieved by a quadratic probability distribution whose upper and lower limits determine the maximum and minimum sampling probabilities, respectively. For the second approach, we fine-tuned 7 state-of-the-art classification models to determine which cardiac region each slice belonged to. We also trained 3 region-specific segmentation models using slices from the corresponding cardiac regions only. Finally, we combined the best-performing classifier with the individual segmentation models for our predictions. For approach 1, we tried 2 batch sampling levels, low and high, by setting the ratio of maximum to minimum sampling probabilities to 4 and 20, respectively. A higher level of batch sampling produced better results in our experiments. For approach number 2, we compared 7 classifiers according to the weighted average precision and recall values for all cardiac regions in the NHS test cases. The best performing classifier, DenseNet, was combined with the region-specific segmentation models. Additionally, the ground truth cardiac regions were combined with the region-specific segmentation models to determine the upper bound performance of this approach. This figure shows the interpolated DICE score distributions for the NHS test cases for the baseline, the best performing proposed approaches, and the ideal classifier and segmentation. The classifier and segmentation approach, shown in green, produced the greatest performance improvement for the base and the apex. Furthermore, the ideal classification and segmentation, shown in red, indicates that relevant improvements could be achieved by further improving the performance of the cardiac region classifier. Finally, this table shows differences in DICE scores between the baseline and the proposed approaches for the base and the apex. Positive values indicate improvements over the baseline, with the largest improvements highlighted in bold for each approach. The results show that the classification and segmentation approach outperforms both the baseline and the non-uniform batch sampling approach across all labels and datasets. Statistically significant differences between the means of the baseline and the proposed approaches are indicated by asterisks. In our work, we have shown that there are significant segmentation performance differences between the middle of the heart and both the apex and the base. These findings are actually in line with experience from clinicians in daily practice. Besides, these regional differences are critical for clinical evaluation because they can have an impact on the estimation of functional cardiac metrics, such as stroke volume and ejection fraction. Using the NNUNet segmentation framework, we have proposed two approaches to bridge this performance gap. The first approach allowed us to modify how often CMR slices from different cardiac regions are seen during training. The second approach combined a cardiac region classifier with region-specific segmentation models with the aim of having specialized models for each cardiac region. Our results show that both approaches improve performance in the basal and apical regions, although only the classification and segmentation approach produced significantly better results across all labels and test datasets. Furthermore, the results for the upper bound performance of approach 2 are quite promising, as they indicate that further improvements could be achieved by improving the performance of the cardiac region classifier. Motivated by the current results, we aim to train deeper classification models to improve our current cardiac region classification performance, to investigate a simultaneous classification and segmentation approach, and also to analyze how an improved segmentation performance affects the estimation of cardiac function metrics such as diastolic and systolic ventricular volumes, ejection fraction, and left ventricular mass. Thank you very much.